YouTube. I just wanted to come real quick and say, for the first minute and 29 seconds, I want to say, of that video that you're about to watch was somehow deleted. And I wanted to give you the preface of it, or preface of it, or whatever it's called, of the video before we jump right into it. So basically on this shift, it's an abbreviated shift. I only worked 6 hours that day. And I split a shift with a nurse, and I worked from 1 p.m. to 7 p.m. And so that's basically where this picks up at, that I was just basically saying that I had just got my patients from the other nurse. She had already assessed the patient, so there was not really a reason. And she'd already did the 2 o'clock vital signs and all the midday assessment. So there was not a need for me to go back and redo them. My next assignment wasn't until about 3 o'clock that I had to do something for a patient or something along those lines. So I wanted to go ahead and explain it to you before we jump right into this video about what actually happened that day. So you're like, what is she talking about? Where does this even start? That's where it started. I went in at 1 o'clock that afternoon to work, and the rest you'll check out here in the video. All right, let me know what y'all think. All right, so as I was saying, I just handed her her ice pack. And that's pretty much it. So the nurse who was here before me, she did all the 2 o'clock rounds, so I didn't have to come in and do much. I did admit a patient, a vaginal delivery, who had our first baby, and I got that done. At our hospital, we do postpartum depression screenings on all of our patients when they first get into postpartum. Is that something that you all do at your hospital? Just comment that below if you do OB. Do y'all do postpartum depression screenings on your patients? So we do that on all our patients upon admission to postpartum. That's pretty much it at the moment. I don't have anything due. I did pass a Motrin that was scheduled for 3 o'clock. It is now 14:40, so I have about 4 hours to go. I love working 6-hour shifts, better than the 12, so I will split a shift anytime if somebody wants to do so. I guess since I have some downtime, I actually brought my computer to actually work on some homework. If y'all don't know, I am a doctoral student, and I graduate in May, 133 days from now. I graduate, and I actually need to write my goals up for this semester. So I want to talk a little bit about my goals for this year. I don't really do New Year's resolutions, but I do use January 1st as a time marker to say this is when I started something, so I'll have an official date of when I can measure my results against whatever I started. So like, I started working out officially January 1st of 2018, so now I knew January 1st of this year was my 2 years that I've been working out. So I'll use it as a marker, but not really as a resolution. So goals for 2020, obviously to graduate from my doctoral program, to be more active if I can on YouTube in terms of my content, more nursing material, things like that. Stop complaining as much. You all know I hate coming here, but I have to work, so I need to go ahead and kind of embrace that in terms of not complaining so much, because there's people out there who don't even have 1 job, and I have like 4. So, and I have 3 people who are offering me jobs right now, which I can't take because I'm in school. So I just stopped complaining. Something else. I need to work on my goals for school, which are due. They're actually due now, because I'm supposed to start clinical on Monday. So we'll see. 240 clinical hours is what I gotta get done by Monday. Not by Monday. Starting Monday to the end of the semester, which is May 8th. So, what else? I don't really know. I'll come back. If I think of something, I'll come back. I'll talk to you later. Okay, I just wanted to basically show you all what our nurses station looks like. You see the division clerk sitting there. We have our copier, printer, our tube system, our sink, Pyxis. Our IV fluids are over there. Our syringes are over there, needles, things like that. They should be locked up, but they're not. Nurses, little cubbies, that's where I was sitting with my cereal, and that's where the other nurse is sitting with her blanket, as you can see. Then back to the hall. You see a hallway. All right, so I am back. It is now 17:52, and it's been quite eventful. Let's go in here so we can talk. Cut on this light. All right, so just for an update, it's been quite eventful. I have 5 patients, but the highlight of my shift was helping another nurse. So we had a situation where the nurse pulled the emergency cord out the wall. So we have the call light, and when it comes out the wall, it sends an emergency signal out. So sometimes patients do it by accident, but sometimes when a nurse is in a certain room and she pulls it, we know to come running because she told us this patient was something serious. So go in there, and the patient is diaphoretic and she's just acting not with it. And so I was taking her blood pressure for her, and we were waiting to get a phone call back from a doctor for her patient. When we did that, as I'm waiting for my blood pressure or the result to come up, we couldn't get a result. She's telling me she feels like she's gonna die, things like that. So I'm like, okay, well, not today, not dying today. So ended up what happening was, by the time the nurse came back, I said, you need to call a rapid response for this patient. Blood pressure is 185 over 115. I said, she's diaphoretic, and I said, she's losing consciousness. We need to go ahead and call a rapid response. So we called the rapid response, and I don't know her whole history again because she's not my patient, but the team came, they got her stable, and she ended up getting transferred to ICU. So one thing about a rapid response team is the fact that they come in and assess the situation and decide whether she needs further intervention or not. You want to do this before you call a code blue, obviously, because she's showing a change in status. According to the nurse, she was fine earlier today, and now she's acting kind of funny, so I don't know. Anyway, she is taking steroids, albuterol. When you take albuterol, it does make you act, some people, kind of crazy. So we don't know if she really has a psych issue. Well, yeah, she has a psych issue. She has a drug issue. And I said she's withdrawing from something. I could tell by the sweating, and she told me she was on fire. When they tell you that, and they sweating and carrying on like that, I'm like, she's withdrawing from something. Again, not my patient, don't know the whole history, but I knew something was wrong. I do know for a fact sometimes we have difficulty in getting doctors to respond fast enough to the nurse's calls, in terms of like, okay, this nurse who is in charge of this patient called 4 or 5 times for the hospitalist to come, for the physician. Actually, the patient was already discharged to go home, and I'm like, okay, clearly this patient's not able to go home. She's not stable. So they're saying, well, this is a status change for her not to be stable, because at the time of discharge, or at the time that the doctor discharged her, she was stable. Again, clearly she is not stable. Something is not right. We got to do something. The nurse kept on saying, I'm gonna call the doctor, I'm gonna call the doctor. The doctor was not doing anything. And I keep telling people, if the doctor is not doing something, then you as a nurse can take the next step. I'm like, call a rapid response, because the rapid response team has to call the doctor themselves and say, this is the situation, what do y'all want to do? They made the decision then to take her to ICU. That's where she needed to be. I said, she needs to get off this floor. This is not a case. OB-wise, she was clear, but she definitely had something else going on. I want to tell you all, do not be afraid to call your rapid response team if you see a patient status change. It could be something that's just the blood sugar changes, it could be the blood pressure is going up, it could be a mental status change, it could be lab values change, it could be pain that's not resolved. Utilize your rapid response team. They are the ones who come and help you and help assess what's going on and help provide interventions, treatment, and another set of eyes, basically, to say this is what's going on with the patient. I have become the queen of calling rapid response on our floor. Everybody's like, every time something happens, Marita is the one with the patient, and she's not even my patient, but we have some of the worst, in terms of, not worst, what's the word, higher risk OB patients. So therefore, when we have these patients, basically something has to happen. And sometimes the nurses that I work with are not well versed on being aggressive or assertive, and I'm very assertive. I'm like, okay, this is what we're gonna do, because I'm not gonna keep on chasing my tail, so to speak. And it's not even my patient yet again. I'm not gonna keep chasing my tail. You've called the doctor 4 or 5, 6 times, and I've only been here since 1. So, and we called the rapid response at 15:58. So right at 4 o'clock, we called the rapid response. They were here within 4 minutes or so. My point is this: if this nurse has been dealing with this all day today, I've been here since 1. We call at 4. The whole 3 hours I was here, she's calling doctor after doctor after doctor, and nobody's doing anything about it. So I said, you know what? We're calling rapid response. I made the decision. So I made the decision to do so. I have no regrets. The patient's now being cared for on ICU, where she has, I wouldn't say better care, but she wasn't a fit for our floor any longer. So like I said, I'm quick to get somebody off our floor. You have to be a patient advocate. You have to be a nurse advocate. You have to protect that license. It would have done us no good to keep this patient on the floor knowing she needed more help than we could provide. I have no problem doing so. So anyway, go ahead and you all need to research what your rapid response team does cover and what they don't cover, and when you should call, what the protocol is for calling your rapid response team. That is something that's very important to make sure that you know how to properly care for your patients, how to transfer your patients off a unit if need be, how to have the doctor involved in care, or what you need to do when you need to transfer care or get a doctor's attention. Sometimes it's about shock value. They don't believe you, they don't trust you, whatever. They not dying on me. That patient told me when that nurse left, I was watching her patient, she said, I'm gonna die. I said, not today. And that's kind of how we ended that, and we transferred off the unit. So anyway, be an advocate for your patient, be a nurse advocate, protect your license. That's the moral of that story. I have done my 1,800 rounds. I have 5 patients still. I have a C-section that I've already cleaned up and did her peri-care, vital signs, things like that. She passed the golf ball size clot, so I did a vigorous fundal massage on her as well. Made her aware that she passed this clot so she would know what to look for and what to let us know about. I passed my 1,800 Motrins already. I had everything done before 6 o'clock. That's how I like it to be. I'm about to now take my time to chart all these assessments that I've just done, or follow-up assessments, vital signs and pain that I've just done. I'll come back and check with you later. All right, so I am back. I am out in the car. It is now 19:22. I have finished my shift, given a report, and nothing really has happened since I last saw you. I documented my vital signs, my fundal assessments, and things like that, gave a report to the oncoming nurse, and I clocked out, and here I am. I actually, I only worked for 6 hours, so I can't complain. Nothing really bad happened besides that rapid response situation. The patient was on meth and was having withdrawals, basically, and unfortunately, because of just how it is here in Tennessee, I'm able to pick up on those signs and symptoms really quick, and able to get them to where the help that they need to get really quick, so that they could get help, basically. And I know our floor is not for that. We don't do that on our floor. So and OB-wise, she was cleared of her issues. She was being discharged today, and that's another point too. Just because your patient's being discharged that day, she wasn't my patient, but just because the patient's being discharged that day, you still have a responsibility to the patient to look at signs and symptoms and see if there's a change, and call your physician back and say, okay, even though we've discharged this patient, this is what's going on. You will have physicians that will not like you for doing that, because once they've discharged the patients, they don't want you looking for anything else wrong with these people. But I came in at 1 o'clock, and with this particular patient, I'm up here kind of like, why is it that we were discharging this patient when you could hear crackles when you walked into the room? I could hear crackles and wheezing walking into her room. So no stethoscope. I could just hear them walking into her room. So how is she safe to go home sounding like this? So you have a responsibility, and supposedly she wasn't sounding like that this morning when the doctor discharged her. So apparently she had a status change, and that's kind of what I keep telling the nurse that I was working with. If there's a status change, I don't care what the discharge says, she cannot go home sick. In your best, trying to take care of a patient, she cannot go home being sick. So be mindful of that. I don't care if the patient, if you are truly a patient advocate and you care about your license, if they're discharged, again, the doctor does not want you going looking for anything else, typically. But if there's a status change, you have to take care of your patient and take care of the patient's needs. That's something that's just required as a nurse. So be mindful of that, and don't be afraid, again, to call up a response if you need to, and don't be afraid to call the physician as many times as you need to. I do not care how often you get on their nerves. You are there to be a patient advocate and take care of your patient. So go ahead and make sure you do that, and definitely don't be bothered by how often you have to call the physician. Now, if you're concerned you're calling about something that's not really important, talk it over with the other nurses that you work with that you trust, and then see what they think about that, because that way You can run scenarios by them and say, oh, don't call about that. Just try this. And if it works, fine. If not, whatever. Follow your policies and procedures, but definitely don't be afraid to utilize calling the physician if need be. Anyway, that's my tip for today. I talked about my goals for the year. Nothing really, significant, but things that I want to work on to better me. And I always want to better me every single day. I'm always working on a better me. So I'm about to head home and rest, and actually work on my goals for my program for school and get those uploaded and sent to my advisor so I can start clinicals on Monday. Anyway, until the next time, you all take care.